Hello, my name is Jelena Misita and I work for SAFE. We're talking today about stroke prevention with stroke prevention professional and expert in this field, Dr. Edo Richard. Could you please tell us more about yourself?
Yes, good afternoon, Jelena. So my name is Edo Richard. I'm a neurologist from the Netherlands. I work at the Radboud University Medical Center in Nijmegen, the Netherlands. And I'm very much interested in the prevention of cardiovascular disease, stroke, and dementia. And these all three share the same risk factors. And I'm doing a lot of research on this. And in addition to the research, I'm seeing patients in our stroke unit and memory clinic.
It's a pleasure having you today at this conversation, at this call. Could you please tell us more about why is stroke so hard to prevent, even when we know which risk factors are accountable for around 90% of strokes?
Yes, this is a very good question. And there's not one single answer because it's a difficult issue. To start with, many people are actually unaware that they have stroke risk factors. And this has two reasons. First of all, a lot of people just simply don't know what risk factors for stroke are, simply because nobody ever told them. In the second place, many of the risk factors for stroke, they go unnoticed. So you don't notice if you have a high blood pressure, you don't feel it. You also don't feel it if your cholesterol level is too high, or if you have a mild form of diabetes. All these risk factors, which are very important, they go unnoticed. And if you do know what your risk factors are, most of them can be challenged with adapting your lifestyle. But this is something in general that people find extremely difficult. Having a healthy lifestyle is difficult when you have a busy life and you need to have something quick to eat. People prefer their car over their bike. People in general like unhealthy lifestyles. And changing your food habits, for instance, is very, very difficult. People get used to the kind of food they eat. They live in a certain society where specific types of food are eaten often, which can be unhealthy foods, and it may not be so easy to actually change that. And what makes it even harder is to change lifestyle in a sustainable way. Because, of course, a risk factor like overweight, people know that they are overweight. They look in the mirror, they see that they are too heavy. And very often, if they're really motivated, they succeed in losing a few kilos. But then the problem is maintaining the lower weight. And before you know it, people are back on the weights they had before. So this is really difficult. And finally, a very important other risk factor for stroke is smoking. But smoking is different from the other risk factors because smoking is an addiction. Addiction is also a disease. Most people don't actually like the fact that they smoke. They know it's bad for them. They know it causes cancer or increases your risk of stroke or heart disease. But because it's so addictive, it's very difficult to quit.
Okay, thank you. But it seems to me that all of these problems, although they apply to majority of people, they are not addressing those people who actually cannot afford to eat healthy food. For example, poverty can be also considered as one of the biggest stroke risk factors, because in poorer countries, even though people can get information about stroke risk factors, there is just so much they can do if they cannot afford to eat healthy or to have some healthy lifestyle. I spoke recently with some doctors, and one doctor from Eastern Europe, she told me, she said, yes, we know what are stroke risk factors, and yes, we are talking with our patients regularly about it, but what's the point of me recommending a patient to eat Mediterranean diet and blue fish if all he can afford is junk food from McDonald's or similar? So this is also a very important thing I think, to stress that people should try to live a healthier lifestyle according to their own specific abilities and financial situation. But what was you were one of key persons for the Stroke Action Plan for Europe, and could you share with us what was your personal experience with this project, being a chair of the first domain working group, primary prevention? Was that as challenging as you saw it in the beginning, or did you find it more interesting than challenging? And in general, what was your experience with it?
Well, yeah, it was interesting and challenging. And one of the challenging things is actually what you just referred to, and that's the challenge of socio-economic deprivation in Europe. There's a lot of inequality in Europe. And I fully agree with you that for people with a low income or also people with low education, and often these two go hand in hand, it's extremely difficult to get out of the way they currently live and to change their lifestyle because they simply cannot afford it. So one of the major challenges for the Stroke Action Plan as a whole is to overcome socio-economic inequalities, because Europe is large and there are very different regions with very different habits, but also with very different socio-economic positions. So I think this is one of the major challenges of the working group as a whole. As a chair of the first domain working group, primary prevention, to start with, it was a very exciting process because the domain was new compared to the previous action plan from 2006, where primary prevention was not explicitly mentioned as a separate topic. So we had to start from scratch. But I had an excellent team working on the primary prevention theme with a broad range of expertise related to prevention, ranging from primary care to tertiary care neurologists. So general practitioners were involved, but also neurologists working in an academic hospital. So this gave altogether many different views. And in addition to the discussions we had within our own primary prevention work group, I thought it was extremely relevant that the group as a whole met in person, but also with teleconferences, so that people from the other domain groups could also comment on the work that we were performing in the primary prevention domain and vice versa. So because we were interacting so much, we were able to deliver a comprehensive document, which I think has a clear line and are not separate chapters, but is really one document.
I would like only to remind our readers that both scientific version and a popular version of this document can be downloaded from SAFE and ESO websites. Further on, what would you advise, going back to our first question, what would you advise to people who actually know what their stroke risk factors are and that these risks are elevated, and what could they do specifically to prevent stroke? What would you advise to them?
Yeah, it's a good question, and it's again a difficult question, but it all starts with education and knowledge. So I think just telling people you have an increased risk of stroke because of your high blood pressure is not very effective. People should really learn what the relevance of these risk factors are. Do they really know what the different risk factors are and which risk factors are important? And also importantly, do they actually know the consequences of stroke? For instance, many people don't know that stroke can also lead to dementia. And I think what people should also be aware of is that the risk factors for stroke are the same risk factors as for heart attack. So it all starts with being well informed. And I think if people find it difficult to understand what actually it means to be at increased risk of stroke, I think it would be good to visit a doctor and really ask a doctor about the explanation. And this is, of course, what you can do as an individual. Later on, I think we start to talk more about what we can do as a society. And secondly, once that you are educated and you really understand the importance of stroke risk factors, people should become convinced that they actually can do something to reduce the risk of stroke. Because often people have the impression that it just comes as it comes, that if you get a disease, it just happens, and nothing you can do about it anyway. But this is of course not true when we're talking about treating risk factors for stroke and other cardiovascular disease. So people need to get convinced that they can do something themselves. And at the same time, they also have to know that they're not on their own, and that everybody knows that improving your lifestyle, losing weight, stopping smoking, starting exercise, that all of these things are challenging. And that it's perfectly fine to ask help if you cannot do it by yourself. And for some people, for instance, peer-to-peer support really works well to do this kind of lifestyle changes together with other people who also have risk factors for stroke. And it's important that if there are challenges, for instance, as we discussed previously, there are financial challenges, something simple as getting running shoes to actually do your exercise. If these things play a role, I think as a society, it's important that we facilitate people to have the minimum required situations to be actually able to do, to improve your lifestyle and to work on your risk factors. But again, it all comes down to information and education. So people also need to know where they can get this information. And this is, of course, different in each country within Europe.
So to sum up your recommendation within this answer, you think that all starts with information and education, but any person should not be individually responsible for their stroke prevention, because it's a collaborative work and they need social support, both peer support and support from their country, right? Did I understand well?
That's a very good summary. Thank you.
Okay, so about this stroke action plan for Europe, can you give us a little bit more background information about the targets? Are these targets ambitious? Are they achievable in the next 12 years? And how do you see all of this unfolding in the next 12 years?
Yes, we tried very hard to be ambitious and realistic at the same time, because nothing is as discouraging as setting targets that cannot be reached. This is the same for losing weight. If you say that you want to lose 10 kilo within 5 weeks, this is not realistic, leads to frustration and demotivates. And the same is true for the targets we set as scientists and clinicians. So we really wanted to set ambitious goals, but we certainly also wanted to set realistic goals so that in 12 years we can conclude that we have been able to actually reach most of our targets. And one of the most important targets is to overcome disparities in Europe. This is also an overarching theme, and it comes back in several different chapters of the document on the action plan. And an important thing that we should work on for the coming decade, and what really should be a target, is to learn more about which treatment is best for whom. We more and more come to realize that one size does not fit all. We now target the same blood pressure for everyone, we prescribe the same cholesterol lower for everyone, etc., etc. But probably there are individual characteristics of people that make that for some person a certain blood pressure is optimal, whereas for another person it may be slightly different, for instance, because there are other comorbidities in addition to the risk of stroke. And something that we thought is very important for the action plan as a whole, but specifically also for the primary prevention topic, is that we really need a national strategy. We need a multifaceted approach. It's a combination of targeting the individual, making people partly responsible for their own health, but at the same time use a community-based approach. And really, we really need the political will for that as well, because we are talking about an actual public health priority. For instance, a risk factor such as only unhealthy food being available, or even broader air polluted individuals cannot work on themselves, that doctors have hardly any influence on, but it really requires the political systems within countries, and actually preferably of collaborating countries over Europe, to work on. And another thing that we found very important for the targets for primary prevention for the next decade is that we think better screening for risk factors in those for whom it is indicated. Not everybody needs to be screened from the age of 20 for risk factors. This is not necessary and not relevant, but we need to figure out better who should be screened at which age, and then we should implement that. And finally, if you look at our targets for 2030 in the primary prevention domain, you see that our last target is to have blood pressure detected and controlled in 80% of all people with hypertension. And we chose hypertension for several reasons. First of all, because it's a very common risk factor. Second of all, treatment is very cheap and readily available in all countries in the world. And thirdly, of course, it is a very important risk factor for stroke and also for other cardiovascular disease. So we did not choose blood pressure because we think the other risk factors are not important, but we did want to set something which is ambitious and realistic, and from that perspective, we chose for blood pressure. And 80% detection and control is ambitious, but we think it's feasible. And therefore, we don't say 100%, because that's also ambitious, but not feasible.
Okay, so you've mentioned a number of targets and a number of challenges. What do you think will be the first challenge in implementation of this domain's goals?
I think the first challenge is to create momentum for national action plans. Some countries in Europe have already a national action plan in place or are preparing it, but other countries do not have such a national action plan. And it really requires a lot of effort to get all partners involved aligned, because that's patient organizations, patients themselves, doctors, public health specialists, policymakers. All these people need to be aligned and need to all be convinced of the relevance of getting such a national action plan. That's the major first challenge. The second major challenge for implementation, I think, is to actually reach the people in deprived communities. Those are the people who are currently often not reached, but they are at the highest risk because of their low education, because of they have financial problems, but for instance also think of persons without a permanent residency. These are vulnerable populations in society who are at the highest risk, but our current prevention strategies tend to reach the higher educated people who are already at relatively low risk and try to improve that a little bit.
Thank you. Thank you for today's conversation. I think we learned a lot of interesting stuff about Stroke Action Plan for Europe and how it will unfold in the next 12 years. I'd only like to remind people to download it from SAFE website, www.safestroke.eu, or from ESO website. And this interview will be placed on a website which is entirely dedicated to stroke prevention and education about stroke risk factors. And it's strokeprevention.info. Thank you, Dr. Richard, for today's conversation. It's been our pleasure, and we hope to hear more from you when the implementation of this plan starts.
You're very welcome. Thank you for this interesting conversation.